Hello everyone, thank you for watching my presentation. I'm Nariko Katayama from Keio University in Japan. I will be presenting the findings of a randomized controlled trial study titled Functional Connectivity Changes Following Cognitive Behavioral Therapy in Depression. Cognitive Behavioral Therapy (CBT) is widely recognized psychotherapy for patients with major depressive disorder. However, the neural mechanisms underlying the effectiveness of CBT, particularly its impact of future thinking processes, remained unclear. Our previous task-based fMRI study revealed a reduction in frontal pole activity during future thinking following CBT, which was initially higher in depressed individuals compared to healthy subjects. In this oral presentation, we aim to assess the differences in pre- and post-treatment changes in resting state functional connectivity in brain regions associated with future thinking between CBT and the control intervention, talking control, TC. So our research question was, does CBT alter rsFC between the brain regions related to future thinking differently than TC? The study employed a single-site 16-week RCT with two parallel arms and a 12-month follow-up period. We recruited 38 patients diagnosed with major depressive disorder based on the DSM-4 criteria and mild to severe depression symptoms, which are assessed by Hamilton Depression Rating Scale scored greater than 16 at the beginning of the study. The intervention consisted of face-to-face individual sessions of either CBT or TC, once a week for 16 weeks alongside routine clinical care. CBT sessions followed Aaron Beck's treatment manual for MDD, employing cognitive restructuring and problem-solving techniques to challenge distorted cognition and behaviors. TC sessions, on the other hand, provided unstructured supportive psychotherapy as a comparator therapy for the guidelines. Clinical assessments were conducted at baseline, post-treatment, 6-month follow-up, and 12-month follow-up. Depression severity was objectively evaluated using Grit-HAMD-17 as the primary clinical outcome measure, while the automatic thought questionnaire revised ATQR assessed negative and positive automatic thoughts as secondary clinical outcomes. Imaging assessments were performed at baseline and post-treatment using resting state functional magnetic resonance imaging rsFMRI on a 3 Tesla MRI scanner. We examined changes in rsFC in the frontal regions, nucleus accumbens, amygdala, and other limbic structures associated with depression and future thinking. Clinical data analysis was conducted using SAS, employing a mixed effects model for repeated measures to estimate group differences in depression severity over time. Imaging data analysis was performed using SPM12 and CON in MATLAB. We employed a 2x2 mixed ANOVA interaction analysis to assess changes in rsFC between groups and over time. Furthermore, Pearson's correlation analysis with bonferroni correction examined associations between rsFC and clinical symptoms. Here is a consult diagram illustrating participant flow throughout the study. Here is the participant characteristics. Our first set of results focused in the differential change in rsFC between CBT and TC. We observed significant time by treatment arm interactions effects in rsFC between the right frontal pole and right nucleus accumbens, as well as between the left frontal pole and left nucleus accumbens. Additionally, rsFC between the right nucleus accumbens and right paracingulate gills showed significant changes. Moving on to our second set of results, we found the significant group by time interaction effect in Grit-Hamdi-17 total scores over the 12-month follow-up period. This indicated differential changes in depressive symptoms between the CBT and TC groups. Finally, our third set of results explored the correlation between rsFC and clinical symptoms. We found that changes in rsFC between the frontal pole and nucleus accumbens were significantly correlated with the total ATQR score and negative ATQR score at the post-intervention assessment. At the 6-month and 12-month follow-up assessments, changes in rsFC between these regions continued to exhibit significant correlations between depressive symptoms. Now, let's discuss the strengths and limitations of our study. One of the strengths is our RCT design, including a control group undergoing TC to eliminate common factors in psychotherapy. We also had a long-term follow-up period and conducted standardized CBT sessions performed by trained therapists. Accordingly, our study assessed brain rsFC using fMRI and examined its relationship with clinical symptoms. However, there are also limitations to consider. The sample size, although sufficient to verify our main hypothesis, may have increased the probability of false results. Furthermore, the single-site nature of our study limits its generality, and the lack of functional MRI assessments in the follow-up evaluations hinders to assessment of causal relationships and predictive power. And although the background factors are randomized, most patients were already undergoing medical therapy as the initial treatment due to the lack of CBT facility in Japan. Therefore, the impact of medications on rsFC should be carefully considered. Finally, although we selected ROIs from previous studies in hypothesis testing manner and performed appropriate FDR correction, caution is required in interpretation due to the increased risk of false positive errors. Our study is the first RCT to compare functional brain changes between CBT and TC in patients with MDD. The result revealed increased rsFC between the frontal pole and nucleus accumbens as prominent therapeutic brain change following CBT. This change was associated with subsequent clinical improvement, indicating its potential as a prognostic factor. In conclusion, our study provided valuable insights into the neural mechanisms underlying the effect of CBT in patients with depression. The differential changes in rsFC and depression symptoms suggest that CBT has distinct therapeutic effects compared to the control intervention. These findings contribute to our understanding of the brain processes involved in future thinking and provided potential targets for further research and treatment development. Thank you very much for your attention. I would be happy to answer any question you may have.